Good evening, ladies and gentlemen. Today, we are gathered here for the annual event that is of utmost importance to all radiologists in Sri Lanka. It is the event that celebrates the culmination of all the hard work and the untiring efforts made throughout the year by the Sri Lanka College of Radiologists. It is a great pleasure and an honor to most warmly welcome you to the inauguration ceremony of the 20th Annual Academic Sessions and the Dr. S.N.B. Talwatha Memorial Oration 2021.
Please rise for the ceremonial procession as it enters the hall. most kindly request you to remain standing for the national anthem.
Thank you. The lighting of an oil lamp to inaugurate a special occasion is a treasured and an age-old Sri Lankan custom. In keeping with this tradition, may I respectfully invite the chief guest, Professor Senaka Rajapaksha, Director, Postgraduate Institute of Medicine, University of Colombo. The guest of honor, Professor Hans Blickman, Professor of Radiology and Pediatrics, Golisano Children's Hospital, University of Rochester's Medical Center, USA. Dr. S.N.B. Talwatta, Memorial Orator, Dr. Hiroshini Kodikara, Consultant Radiologist and Senior Lecturer, Department of Anatomy, Faculty of Medicine, University of Ruhuna. The President, Sri Lanka College of Radiologists, Dr. Gerard Fernando. The Senior Most Past President, Dr. Thurai Raja. Immediate Past President, Dr. Pandula Hettiarachchi. The President-elect, Sri Lanka College of Radiologists, Dr. Dilip Karunaratne. The Honorary Treasurer, Dr. W. Meegoda, and the Honorary Secretary, Dr. Udita Kodituakku, to light the traditional oil lamp.
Thank you. Now, I kindly invite the chief guest, Professor Senaka Rajapaksa, the guest of honor, Professor Hans Blickman, the orator, Dr. Iroshini Kodikara, the president of Sri Lanka College of Radiologists, Dr. Gerard Fernando, the honorary secretary, Dr. Udita Kodituakku, and the honorary treasurer, Dr. W. Meegoda, to take their seats at the head table.
Now, it's my honor to invite the President, Sri Lanka College of Radiologists, Dr. Gerard Fernando, to welcome the dignitaries and to deliver the presidential address.
Good evening. Chief guest, Professor Senaka Rajapaksha, Director of PGIM, guest of honor, Professor Hans Blickman, past presidents of Sri Lanka College of Radiologists, Dr. S.N. Vitalwata, orator, Dr. Iroshini Kodikara, officials of Ministry of Health, families of late Dr. S.N. Vitalwata and late Dr. Atukorala, consultant radiologists, distinguished guests and invitees, and dear friends. It is an honor and privilege to stand here as the 28th President of the Sri Lanka College of Radiologists. I found it to be an humbling experience to be among the great line of presidents of Sri Lanka College of Radiologists who have done much during their times. I would like to thank our chief guest, Dr. Professor Senaka Rajapaksha, for accepting our invitation and being here with us today, despite his busy schedule as a clinician and the director of PGIM. It was a difficult task to organize this Congress amongst the uncertainties of the COVID-19 pandemic. Thank you, Professor Blickman, Professor Satish Sukuma, and Dr. Suresh Fernando for being with us here in person, despite the risk of traveling. And a big thank you to our local faculty and the overseas speakers who will be joining us over Zoom. I will be failing in my duties if I don't thank the Council of the Sri Lanka College of Radiologists, not only for their hard work they did organizing this event, but also for the tremendous work they did and support they offered during my presidency. The organizing committee of the annual academic sessions, the editorial board of the Sri Lanka College of Radiologists, reviewers of the posters and free papers, who did a tremendous job in such a short time, and members of all the subcommittees and our sponsors, thank you very much. There's one more person I need to thank. Thank you very much, Udita, for all your hard work, our Secretary of Sri Lanka College of Radiologists. It is an exciting time to be a radiologist. Medical imaging technology continues to advance. Imagers and our interpretive expertise have become an indispensable part of the diagnostic process, enabling effective and timely clinical care. Even more exciting is that the radiologists not only diagnose, but assess the treatment response, and at times are the primary clinician directly involved in treatment. Radiology has come a long way. From an era where the radiologist was invisible, seated in a dark room reading x-rays, now the radiologists are taking a central role in management of the patient. Diagnostic radiology has grown exponentially. There are new ultrasound scanners with echoes and ECGs, making the stethoscope obsolete. And every clinician from vascular to neurosurgeon and emergency physician wants a point-of-care ultrasound. We are diagnosing diseases such as Alzheimer's and Parkinson's disease early with nuclear medicine studies, even before a clear clinical picture evolves. Interventional radiology has become a separate subspecialty. Angioplasties, aortic stents, treatment of cerebral and peripheral aneurysms, and vascular malformation has become routine. Radiologists are treating renal neoplasms, hepatocellular carcinomas, and thyroid nodules with radiofrequency ablations and transarterial chemoembolizations, where you directly inject chemotherapy tumors via arterial access. In oncology, we are using cryotherapy where you freeze and kill tumors with special probes. US Food and Drug Administration, the FDA, has approved the use of MR-guided focused ultrasound to ablate small targets in brain without incisions. The device has received FDA approval for treating medication-refractory essential tremor for tremor-dominant Parkinson's disease. Continued advances in technology and understanding of disease require increasing radiology skill, which calls for increasing specialization. For example, what started as breast imaging reporting data system, the BIRADS, has now moved on to liver or LIRADS, lungs or LUNGRADS, to PIRADS and TIRADS for prostate and thyroid. This increased uniformity in assessment improves our ability to characterize and treat disease, but adds to the burden of managing an increasingly complex and complicated system. For us to improve, we must understand the varied needs of those whom we serve and better meet the needs of those who we serve. To offer a good radiological service, we need manpower, equipment, and expertise. Currently, we have 144 consultant radiologists attached to the Ministry of Health, and around 25 in the private sector and in universities. Further, we have 79 MD qualified radiologists and around 116 pre-MD trainees who will be qualified consultants within a few years. Though the Western province has almost 1/3 of Ministry of Health radiologists, it also has the largest population and many specialized referral centers. We are providing services to all Type A base hospitals, most of the Type B hospitals, and some base hospitals even have 2 radiologists. No. But we still have far to go. Australia, with similar population to Sri Lanka, in 2016 had more than 2,000 practicing radiologists. Notably, they had 348 MRI machines at the time compared to the 23 MRIs we have at the moment in Sri Lanka. Even the current number of CT scanners we have is less than 1/6 of the MRIs Australia had in 2017. When equipment is considered, we are below par. We are below par even compared to the Southeast Asian countries. Many hospitals, even up to district general hospitals, will have only an ultrasound and X-ray. Only National Hospital Colombo provides a whole spectrum of radiological services. That is X-ray, ultrasound, CT, MRI, fluoroscopy, DSA, nuclear medicine, and PET facilities. Some of the teaching hospitals even lack MRIs, and sadly, there are no MRIs in North Central Province or in the Eastern Province. With more and more subspecialties in the other fields demanding for specialized investigations such as CT and MRI, we lack the equipment to provide them. Sri Lanka has good health indices due to its excellent primary care. The disease pattern is changing. With increasing healthcare burden from non-communicable diseases, the radiology has a means for early diagnosis which can prevent mortality and morbidity, which takes off an unlimited amount of uncalculated cost from the government and people. It is calculated that 50% of cost of healthcare in Sri Lanka is borne by out-of-pocket expenses. And expensive investigations are beyond reach of most people. According to world statistics, a fair proportion of this is spent on imaging. To provide adequate imaging and diagnostic services, we need to invest in equipment. But equipment is expensive. As we can see, the government spending on healthcare has been static over many years, in spite of increasing GDP. The result is an actual percentage decrease in terms of the GDP. Can a country like Sri Lanka afford to have this expensive equipment in every hospital? As a small country with a good road network, we should be developing one major center for a province and a cluster system topped by a central super specialized center. This is the vision of our Health Secretary, Dr. Sanjeev Munasinghe, and we have been discussing how to implement this. It is a concept where you base your expensive equipment in one center in a province, run it throughout the day, and offer machine time to rest of the radiologists in that province. It not only saves money for Ministry of Health, but utilizes machines optimally, and is also a way of retaining and using newly acquired skills of young radiologists who are posted to the peripheries. We have realized that subspecialization is the way forward. During our term, we have convinced the Ministry of Health to increase our subspecialties and appoint subspecialists to places where they can offer maximum services. Though it is due to hard work of my senior colleagues, I have been fortunate to see the first pediatric radiologist and the first interventional radiologist taking appointment in Ministry of Health. There are 7 pediatrics, 7 neuro, and 11 interventional radiologists in training. Ministry of Health also has agreed for musculoskeletal, women's imaging, and nuclear medicine, and we are hoping to start them by at least next year. And soon, cardiothoracic imaging. And there is always a question of invasion of our field. Are we a field facing extinction? So many medical specialties want to do their own imaging. If a radiologist is not there, how many people will you need to read a CT brain? A neurosurgeon to look at the ICH? A neurologist to look for the primary pathology? Eye surgeon to look at the orbits? And an ENT surgeon for sinuses. If one person is going to do all this, the person will be a radiologist in another name. But we may have to learn to share in the future. Even with so much competition from other fields and with possible threats from the artificial intelligence, radiology is one of the top 12 earners in the US. In other countries, radiologists are finding that imaging by other specialties actually may lead to increase in radiologists' workload due to a trail of half diagnoses and queries that need to be clarified. However, in a competitive, demanding field, if we are to stay one step ahead, we need to improve and we need to cater to the demand. How do we do that? Again, a subspecialty is a way forward. We need to embrace the concept of value in radiology. It is not just image acquisition and reporting. It also means that we work productively with each other and with our partners to provide a seamless experience for those who we serve. We need to embrace new technology and implement efficient and reliable processes and systems. We are increasingly being judged by our performance as organizations, not as individuals. We need to promote and project radiology departments, not individuals. The purpose of the radiologist is not only to support the referring clinicians in their diagnosis process, but to be part of the team that manage the patient. We need to follow up our reports, get a feedback, and learn to accept criticism. Radiologists should be the doctor's doctor and function as a true consulting physician. We must welcome interruptions from referring clinicians as a chance to connect around patient care. We must be available at inconvenient hours. Medical imaging is a critical component of modern medicine that is not likely to change anytime soon. It is difficult to imagine a future in which medical imaging becomes irrelevant or is excluded from the care process. Radiology is here to stay, regardless of the challenges it faces. Thank you.
Thank you very much, sir. Next on the agenda is the address by our chief guest for the evening, Professor Senaka Rajapaksa, Director, Postgraduate Institute of Medicine, University of Colombo. I most cordially invite Dr. Gerard Fernando, President, Sri Lanka College of Radiologists, to introduce Professor Rajapaksa to this eminent audience.
Professor Senaka Rajapaksha is the Director, Postgraduate Institute of Medicine, University of Colombo. He is the Chair Professor of Medicine, Department of Clinical Medicine, Faculty of Medicine, University of Colombo. His academic career has been nothing but brilliant. He graduated from Colombo Medical Faculty in 1993, obtaining first-class honors with 10 distinctions and 16 medals and awards, including the Sir Andrew Caldecott Medal for the final MBBS. Professor Rajapaksha joined the Department of Clinical Medicine in 1996 as a lecturer in medicine and completed his MD in the University of Colombo in 1999 and MRCP in 2003. Since 2003, he has been an honorary consultant physician in the University of Medical Unit, National Hospital, Colombo, and is an examiner at postgraduate exams in the PGIM and the MRCP UK exams. He is certified as a specialist in general medicine by General Medical Council UK. He's a fellow of the Ceylon College of Physicians, Royal College of Physicians, London and Edinburgh, and the American College of Physicians. He was the president of the Sri Lanka Society of Internal Medicine in 2018 and the president of Ceylon College of Physicians in 2021. Professor Rajapaksha was awarded the Fellowship of National Academy of Sciences of Sri Lanka in 2019. He was promoted to the professor by merit in 2009, senior professor in 2017, and he was appointed chair professor of medicine in 2021. He was the head of the Department of Clinical Medicine from 2009 to 2010 and director local technical secretariat IRQE project from 2007 to 2010. He established the Virtual Learning Center in the Faculty of Medicine in 2005 and has played a leading role in the development of e-learning medicine. Professor Rajapaksha has over 145 publications in peer-reviewed journals and numerous abstracts. He has supervises several MD, PhD, and master's students. He is a joint editor of Ceylon Medical Journal. He has received many presidential awards for scientific publications and has been awarded the University of Colombo Research Award in 2012 and 2016 and Vice Chancellor's Research Award in 2017 and 2020. He was the Scopus most prolific author for 2011 to 2016 from University of Colombo and is listed among the top 2% researchers in the world in recent Stanford list. May I invite Professor Senaka Rajapaksha to address the audience.
Thank you, Gerard. Good evening, ladies and gentlemen. First of all, I'll probably take off the mask. I would like to thank my good friend Gerard, President, and the Council and all of you in the College of Radiologists for inviting me to speak today and inviting me as chief guest. It's indeed a great honor, and it's nice to know that I'm among friends. We've had a long relationship with most of the radiologists. I've been deputy director of the PGIM for 6 years and director for 2 years. And over that period, we have had a very close relationship, and I must say that it has been a pleasure to work with all of you. I'm not saying it's been easy. It's had its ups and downs, but we've had a good working relationship. And I must say the commitment and the perseverance shown by the radiologists to develop the specialty and enhance the quality of training has been phenomenal over the years, and it's a continuously advancing process. So I'm going to talk about something a little unusual. It's very difficult to talk to specialists in a subject when you're not a specialist in the same subject. So you've got to be careful not to talk about things that you don't know. But of course, we all know the origin of radiology in imaging with the discovery of X-rays by Röntgen. But from that point onwards, the discipline of radiology has advanced, and it's a completely different specialty now. As Gerard mentioned, it is now reaching out into follow-up, into diagnostics, and into advanced diagnostics, and also interventions where the boundaries between radiologists and other clinicians are being crossed in both directions, obviously. So what I'm going to talk about is a slightly controversial subject, which, so please don't take offense if I say anything wrong, but I'm trying to work out how a radiologist thinks. It's a difficult task, but it's very close to what any clinician or any doctor, the way any doctor thinks. And it's a slight analysis on the way we think and the way we take decisions as clinicians, and in particular, the way a radiologist would see. Now, the radiologist is different from the physician like me, because you are directly in contact with the diagnostic modalities. And because of that, what you see, perception, is obviously a very important thing. And most of radiology is the eye of the beholder. So perception is a very important component of radiology. Perception alone isn't enough, obviously, but perception is probably the starting point and the most important thing that a radiologist needs to do if he is to do his job correctly. So at the beginning, as I showed you, there was a simple X-ray of a hand, which was probably what is documented as one of the first X-rays still in existence. But now radiologists are bombarded with thousands and thousands of images. Over a particular week, the average radiologist will see many thousands of images. With the electronic systems in place, you scroll through images, CT scans, looking at hundreds of images at a time. And you are expected by people like me to pick out the tiny little nodule that stands out of the normal, and which will make the difference between life and death, because it's about detecting a cancer or missing it. So perception is important, and you are faced with multiple images, this is a fairly simple image, I would say, and I'm sure you'd agree, but this is the kind of image that you are shown, and you are then expected to pick out something from an image like this, or hundreds of images like this, which are seen in sequence. And how do you do it? So, ladies and gentlemen, there are basically two ways that one picks up an abnormality on an image, be it radiology or be it any other image. The smart radiologist, the expert who wants to show off that he is a brilliant radiologist, is the sort of person who will take one look at the CT scan and say, aha, there is a tumor there, and this is what we are looking for, and that's it. Is that sufficient? Is questionable. And there is still a possibility that you may miss other things by trying to do that. Now, if you look at this image, if you break it down into different components, if you take a tiled image of this picture, all you see is white areas and black areas. Some are of different shapes and sizes, but at the end of the day, it's a collection of white and black. But we all know what it is a dog. Because you just sit back and take a look at it, and it is the image of a dog. There's no question about it. So how does the human mind pick up an image like this and say that this is not a single, not a set of composite images, but one single entity? Ladies and gentlemen, there is a concept called Gestalt, and that is what this is. What it means, if you look at this, the line on the top, I think I can use. Yes. If you look at the line here, although there isn't a single alphabetical letter there, in its true form, you all know that it stands for Gestalt. So the mind adapts and builds an image from components of images. And this is the principle that an organized whole that is perceived is more than the sum of its parts. The final image is the composite image is greater than the sum of its different parts. And this is a very old concept, borrowed by many people and rephrased by many, but probably attributable to Aristotle a long time ago, who said that the totality is not, as it were, a mere heap, but the whole is something besides the parts. And that is an important concept. So how does the mind look at things and group them together, separate them, and identify what should be picked up in the midst of a lot of what is called noise, and pick out what is important? So there are several laws of Gestalt, and I'll just very briefly, out of interest, run through them. If you look at this image, the mind groups together things which look similar. So the mind will group, the eyes will look at this and say, there is a row of things which are black, and there's a row of things which are blue. But again, you can group the circles together and group the triangles together, and that is how the mind separates the different items. And in the image on the right, I can't quite get it working, but anyway, there you are. You see that in the midst of all this, the mind groups together the dots and separates the triangles from the dots. And this is what is known as the law of similarity in image processing in the mind. Then, if things are close together, they are associated together. If two lines are close together, then the mind puts them together and says they are related. And if they are all grouped together, they are considered to be one group of things. It is interesting that even though the colors may differ, things which are collected, which are close to each other, are considered to be related to each other. And that is known as the law of proximity. Ladies and gentlemen, if you look at this image, you see a lot of objects. But if you break them down and inspect them piece by piece, all you see is a few black shapes which don't really mean anything. But put them together, and that is Gestalt. They mean the sum of these individual items are greater than, the whole of them is greater than the sum of the many. So these symbols are pretty obvious, and this is known. And what happens here is that the mind closes the gaps and brings things together if they are of a particular, if they follow a particular sequence. So it's a very obvious thing, but the mind closes the gaps and builds images in your mind. And this is something which when we look at an image and process it, this is something we do. So as you can see, there is a panda, there is a snake, there are triangles which have no real outline, but we all know that the triangle is there, that the cube is there, and that the spikes are there fixed to a ball. This is known as the law of closure. Then there is the law of continuity. We like in our mind, if we see a line, to see it to continue through the line. We follow lines because lines lead somewhere. It's like following a road. And that is why when you drive on the roads, there are lines on the road, because the mind, there may be broken lines, but in our mind, it's one continuous line that we see. And that is the line, those are the lines of continuity. And that is the law of continuity. Because if you break it down, we see this image as this, two separate images kept on interspersed with each other. But it could very well be like this, where it's two different lines. It can have a completely different shape. So you need to look analytically and separate what appears to be from what it really is. A similar example would be this, where it looks as if it's a set of shapes which are kept close together, but it very well might be this. So who knows what the original artist of the image wanted to depict. So that, ladies and gentlemen, is the law of continuity. Then this is the law of common region, where if things are enclosed together, they appear to belong together, and that is the law of common region. If you can see this, these squares denote that this set of dots is grouped together and this set is separate, and here you've got another square. The mind looks at this and says these things belong together and these things belong separately. That is the law of common region. There is also a law of common fate. If things seem to move in a certain direction together, we think that they are related. This in radiology would be the way you look at flow in dynamic imagery, where things seem to flow together and seem to be flowing in a particular direction. So that is the law of common fate. Then symmetry is very important for the human mind. We like to see things symmetrical, and when they are not symmetrical, we think there is something wrong. The human body is basically symmetrical. Of course, the heart is not symmetrical, but most of the rest of the body is quite symmetrical. So when we look at images, we look for symmetry, and we look for disorders of symmetry, where there is a difference and things are not quite symmetrical. This is an image you will see very often, and it depicts what is called the figure ground law. So based on the color which you use as the dominant color, you determine which is the foreground and which is the background, or which is the figure or which is the back. So as you can see at first glance, black is, of course radiologists will see this differently because they see inverted images most of the time. But if you take black as the figure, you see a tree. But change your point of view and make white your figure, and you see a gorilla looking at a tiger. And the same sort of thing is seen on the other side, where there's an image of a lamp, or whatever you call it, and there's two people facing each other. So this is the law of figure and ground. So ladies and gentlemen, these are the different ways that people perceive things, and the way people look at a single image and try to make a conclusion as to what it is. I'm not saying it's a brilliant thing, but still it works for the vast majority of people, and people would like to be experts who will look at something and say, with my expertise, I can just take one look at a CT scan and say that this is the diagnosis. And most of the time they are right. So even though this is just a group of dots moving, you know that it is a dog running along. So the question is this the only way to detect, and is this what we should aim for? There is evidence that this is not necessarily the ideal way to look at an image. And there is a school of thought. There's a lot of interest in the concept that you must take a very careful look, systematically look at each component of an image, because using the Gestalt principle can actually make you miss important signs. There are other things which make you miss important signs, although it will be considered amateurish that you are looking at every little component. A combination of these two is what you require. And a balance between Gestalt, where the expert survey gives you information from the whole, which is greater than the sum of the parts, and also balanced with a detailed analysis of everything you see, a systematic analysis. And if you balance these two things together, which is why radiologists now have reports where they have a template on which they report, so that they make sure that they do not miss anything. So what is required is a balance between the two. So that's about perception and perceiving the image. Very briefly about cognition, because thinking is what ultimately gives you a diagnosis. You can see a lot of things, but you need to take that image, process it, and interpret it in a logical, rational way. And one of the biggest challenges you face there is to differentiate the abnormal from the normal, because that is what the clinician like me, who is seeing a patient, says, I want to know whether this is normal. Is this finding that's seen on an X-ray, is it normal or is it abnormal, and what does it mean? So what is normality and what is abnormal? Is that which is abnormal something which we do not usually see? Is it something which is 2 standard deviations from the mean? Is it clinically significant? You see a lot of anomalies, things that are not quite normal, but are they anomalies which matter? Do they have clinical implication? And if you don't detect them, is anybody going to die? Will it matter? So these are important questions. And therefore, normality and abnormality can be graded. you have obviously that which is completely normal. You have that which is abnormal, but which is of no clinical importance at all. So it doesn't matter whether you detect it or you do not. Then you have things where I am not certain. I don't know whether it's normal or not. I'm unsure. I need more information. I need more data. I need more imaging. Then there are things which are definitely abnormal, but you don't know what it is. And you will all agree that's a common problem that you encounter in practice. And of course, there is that which is abnormal, and the diagnosis is apparent, and it warrants clinical management, and that is the best form of diagnosis that one can expect, and that's the best thing that a clinician can expect of a radiologist. Ladies and gentlemen, what do you think of this X-ray? So when people were just told, report on this X-ray, tell me what you think, about 60% of the people missed a fairly important physical sign that was seen. When they were given cues that this is an X-ray of a patient coming in for a normal medical annual screen, they also missed the primary diagnosis. But when they were told that this is an X-ray, can you screen this X-ray for metastatic deposits, they all picked up the fact that the clavicle was missing. And these are the figures. 60% missed the missing clavicle with no cues, 58% missed it when they were told it's a routine medical, but 83% identified it when they were told that this is for a metastatic survey. So the information you get, the starting point, why are you doing this X-ray, tells you, guides you to making a diagnosis. That is why radiologists ask for a clinical history. And unfortunately, I must admit that even it's our fault as well. Very often you don't get a proper clinical history. You are just told there is abdominal pain, do an X-ray, do a CT, and tell us what you find. So this is another concept that adds value to the diagnostic image, and what is known as the diagnostic imaging value chain, where in order to utilize the radiological information properly, you would need a lot more than just an image in front of you. You would need to select the appropriate investigation, the correct investigation to identify what you are looking for. You would need to generate the image, the right image. Is it in the arterial phase or the venous phase? What is the image? What's the type of image that you're using? And then to observe the image and use the Gestalt and the systematic survey methods to identify what is wrong, and then to interpret it correctly as far as to the limits that you can, to communicate the interpretation to the treating physician, and also, most importantly, to use the information for the benefit of the patient. This is known as the diagnostic imaging value chain, and is something that we can use to add value to the process of diagnostic imaging. So ladies and gentlemen, the clinician sometimes expects too much. We would love to have a diagnosis. This is a patient with abdominal pain, tell me what's wrong. And the radiologist says it's an acute appendicitis, wonderful. That's a brilliant way, and there is nothing to make a clinical diagnosis. We know what the diagnosis is. You'll be really lucky if you can have that, but you all know the difficulties in providing a final diagnosis on just an image without following a diagnostic value chain. What we would aim for is to have detailed findings which correlate with the clinical picture, and that is basically what a good radiologist would be able to do, and also guidance as to what you should do next. So you ask the radiologist, what do you think it is? And he says, this is what it appears to be, and this is what we would like you to do next in order to make the final diagnosis. So what influences our findings if you are an imaging expert and you are looking at an image? What are the things which influence your findings? Obviously, the method that you use, whether it's the Gestalt or a systematic approach, will influence the ability to pick up things which are normal and which are abnormal. There is a thing called search satisfaction bias. You are told there is abdominal pain. Can you have a look at this ultrasound and see what it is? And you say, aha, there is a ruptured appendix, or there's an inflamed appendix. This is the diagnosis. I've got it. I've found it. Eureka. And therefore, you don't look for anything else. But the actual pathology is something else. And that is known as search satisfaction bias. Then there is a thing called availability error. Your judgment is biased by recent experiences. You missed a diagnosis before. You missed a lump on an abnormality on a mammogram, and every single mammogram that you do after that has a potential lung cancer because you're biased, you're afraid of making a fatal mistake again. Then there is this concept of analytical reasoning versus non-analytical reasoning. Both are equally useful and good, and I'm not saying that non-analytical reasoning is bad. In analytical reasoning, you go stepwise, looking at different factors and putting them together, putting them in a chain to make a diagnosis. In non-analytical reasoning, the systems are in your brain, the pathways have been built, and when you see something, you know that it is this, and it's very quick, you are very quick. So the experienced expert uses a lot of non-analytical reasoning. In reality, the analysis is taking place, but it's taking place so fast in your mind that you come to a diagnosis very fast. Then there is the problem of inter-observer and intra-observer variation, and believe me, it is quite substantial. People who are shown the same X-ray on 2 separate days will make different diagnoses in about up to 5 to 10% of cases. So it's quite significant. So, ladies and gentlemen, imaging and processing of the image is the core of radiology, but I'm glad to see that a lot of procedures that would normally have required cutting and chopping of the body have now been taken away by our colleagues, the interventional radiologists. And people are now going in without opening the skin to take out lumps, to ablate things. And the radiologists have now got hands that heal. And that is a very great thing that we have achieved over the years. And you should be very proud of yourselves that you have developed radiology into such an advanced field which can actually change the outcome, change lives, and this is just one of the images that I could find. So ladies and gentlemen, you need eyes, a brain to think, and healing hands. What more can you ask? The only thing you can ask is a good heart to do a good job. I'm very proud to be here today to support the College of Radiologists and to wish you all the very best. And I know that under the able leadership of the President Gerard, you will have a wonderful session tomorrow where you will, I would like your sessions to be blessed with success and wish you all the very best for tomorrow. Thank you.
Thank you, sir, for those words of wisdom. May I now kindly invite the President of Sri Lanka College of Radiologists, Dr. Gerard Fernando, for the honors of introducing Professor Hans Blickman, our guest of honor, to this distinguished audience.
Professor Hans Blickman does not need an introduction to this audience. This is his 6th visit to Sri Lanka. He is an eminent professor in radiology who enjoys giving lectures around the world and is a frequent speaker at Society of Pediatric Radiology, RSNA, RCA, RCR, and AOSPR. Born in Amsterdam, Netherlands, he studied at the College of the Holy Cross, Worcester, Massachusetts, USA, and obtained his first degree in Chemistry and Biology in 1974. He obtained his MD from Boston University, USA, and his PhD from the Erasmus University, Netherlands in 1991. Professor Blickman did his fellowship in pediatric radiology at the Harvard Medical School, Children's Hospital, Boston from 1983 to 1985. During his impressive career, Professor Blickman has been Professor of Radiology and Pediatrics at Boston University of Medicine, Associate Professor at Harvard Medical School, Chief of Pediatric Radiology at Massachusetts General Hospital, Professor and Chairman, Department of Radiology, University of Medical College, Nijmegen, Netherlands, Emeritus Professor and Vice Chairman, Department of Imaging Sciences, University of Rochester Medical Center, New York, and the Emeritus Radiologist in Chief at the Golisano Children's Hospital, Rochester, New York. Professor Blickman has written 9 books and monographs, refereed more than 130 journal articles, and 8 book chapters. He is the Editor-in-Chief Emeritus of EJR, the European Journal of Radiology. Among his well-known books are Radiological Imaging of the Digestive Tract in Infants and Children, Requisites in Pediatric Radiology, and Differential Diagnosis in Pediatric Radiology. May I invite Professor Blickman to address the audience.
That really me? Thank you, Mr. President, Council, distinguished former presidents, distinguished guests, and in total, my dear colleagues in Sri Lanka. It is beyond words how grateful I am to stand up here today, and I will not try to explain how I feel anymore. Until yesterday, tea time, I thought that these were the words I was supposed to speak to you today. Dr. Fernando, however, informed me that I was to talk to you a little longer than these couple of seconds. And since then, I have tried to figure out what can I tell this august audience. But he gave me a hint. And Dr. Fernando told me he was going to talk about the road forward for radiology. And now that is a subject matter near and dear to my heart. And I thought I would give you what my children would call the boomer view of what I think the future of radiology is going to be. Now, of course, most of you would like to stand up here and be totally optimistic and say that the world is at our feet and that the only way you can make a diagnosis in the hospital or in medicine in general is with a visit to radiology, which, except for psychiatry and dermatology, is actually true. But that's not how I decided to approach it. I decided to go back in time and go over briefly over a talk I gave between the years of 2005 and 2011 when I was much younger, much more optimistic, and I gave this talk a number of times on quality control, workflow organization, and process redesign in a filmless imaging department, because in 2000 I became chairman of a department with the charge to take it from analog to digital. Well, that is quite a task, as you all know, because you've all done it too, and at the time we were one of the first ones to tackle this problem, and we were all very optimistic. We all realized that this was where we had to go. If you look at how people use our data, if you look at how people distribute the data, more importantly, how we generate the data and store the data, something had to be done. And somehow, the upcoming computer age had to help us. We figured that we had to do that in steps, and we did. And eventually, a digital radiology department, but by extension, a digital hospital, started to take form. As some of you, or probably all of you, remember how in the olden days, we used to have these film bins, all right, over here. And in them were, of course, lots of films that we had to read. We couldn't read them every day. We left them. Obviously, orthopedics came and took them away. And in short, it was a difficult situation that we thought we could cure by going digital. And these next couple of slides that you see, I did something totally wrong. Okay. Come on. Sometimes the electronics go too fast. You can see that we eventually started reading from a screen, and the lost films and the film libraries were a thing of the past. Now, that led to a lot of changing in thinking. And we used a helicopter view. Or, to be more blunt about it, this is how we sold it to the people who had the money. Return on investment was a word that we used a lot in the early 2000s to convince the board that we needed the money to do this, and there would be a return on investment, not 5%, not some monetary value, but we were going to be phenomenal in our service to our clinicians. Yes, more IT was needed, and we thought that as the leaders in IT, because in those years we would handle that fairly easily. Yes, it would make us more dependent on technical support, but we also didn't need people in the film library, and if we could reschool them, that would not cost any positions. IT and tech support, of course, are closely related. Interconnectivity was our buzzword. We wanted to tell everybody that radiology was the spider in the web. We knew how to make this run efficiently. The upgrade, of course, would be system-wide, not just the Department of Radiology. Access for all. As you well know now, the clinician can turn around the screen on his or her computer and show the patient what the imaging is and what was seen. Patient safety was a big driver, and I think we have made some progress, although if you look again, helicopter view, we haven't done too much improvement in this overall safety for the patient. QA became a big, big thing because you cannot manage what you cannot measure. So everybody got into the measuring bit, and therefore we learned that radiology wasn't, or medicine wasn't as safe as we thought it was. Yes, money played a role, but we tried to play it down. In the digital radiology department, there were side effects, of course, but they really were major shifts in the hospital. We did not see all of this coming, to be very honest. The board of directors we pretty much had in our pocket. We thought we were the cat's meow. We were the ones that would handle everything for them. The IT department loved it so much that they became the leader department in most hospitals, because after all, where do you go with computer problems? You go to the IT department. The strong technology push also took this initiative out of the hands of the imaging department. If you look around, radiology does not, at the moment, lead all the changes, certainly not when they are on a technological, of the technological part of it. And the hospital departments all got direct access. Oh, I remember the orthopedic department laughing. Hunting for films was history because they were all on the web or on your computer. And we had accessibility issues gone because everybody at any time could look at the films. We didn't quite think about what we're going to do with the reporting, but I'll get back to that in a second. Lots of projects, lots of research, all of those things we thought were going to be terrific and fantastic, and most importantly, radiology-led. Unfortunately, a lot of young, smart people are in other fields than radiology. So they thought they could do all of this as well. How can they manipulate the images? How can they do the post-processing? How can they put color on the coronary arteries and stuff like that? And the current state has actually accentuated, because of COVID, that the workplace of the radiologist becomes almost virtual. Now again, that sounds unbelievable. Pretty cool, in fact, right? I can sit here in Sri Lanka and read films in Boston. Dedicated workstations everywhere. Everything is high-res, high-intensity, speech recognition. I recently was asked to consult in Suriname, a part of the Netherlands, and they still write their reports. That was quite a way back when I last did that. 3D functionality, of course, for all of the people in this audience are second nature now. And CAD was the term that we used to use before AI became the buzzword. And as you can see, we're going to talk about that also in a second. And the work list for exams made those bins of films obsolete, but they also reminded us how slow we were, how big the volume was, and became bigger and bigger. On call for a radiologist until, let's say, the 80s was rarely used. For residents, most of them, not only radiology, it was a badge of honor if you didn't call your on-call physician, because after all, you had to show them that you could do it yourself. Now, they can call us anytime, and they do. 3 o'clock in the morning. Why have I not got a report on that CT that was done 4 hours earlier? And of course, teleradiology is big. not what we used to think it was going to be, but reporting lag. UK is an example, but in the US they're not far behind. They just can't keep up with all the films that are being made to have the radiologists be able to report them all. And of course, the shortage of personnel is everywhere. And I mean radiology personnel. People going into radiology is a tough discussion. One, because society has changed. When I went into medicine, I know, centuries ago, but when I went into medicine, it was a calling. It is now a job. And correctly so. Particularly, very, very happy to note that the overwhelming majority going into medicine in the United States and in Holland, those are the figures I know, are women. And very good, but they also insist on having a home life, something that we were not even allowed to mention 50, 60 years ago. All of these things contribute to radiology changing everywhere and in every way possible. So, in my opinion, there are three major issues facing radiology today. And it all goes to a quote that I learned about a decade ago, that if you are not at the table where things are being discussed as a radiology department, you are apt to become the main course, i.e., they will eat you up. Because after all, a neurosurgeon can manipulate the data at 3 o'clock in the morning just as quick, if not quicker, than the neuroradiologist. Because the neurosurgeon is going to operate at 5 a.m. And we may or may not be in-house or reachable. So the timeliness is a big problem. How are we going to make sure that we are there 24/7? And in my opinion, if you're not there 24/7 in some form or another, I am not saying I have the answer, but we're going to have a very tough time. If you look at value-added radiology, you know, the American College of Radiology talks about value-added radiology imaging 3.0. It's all about quality, quality, quality. It is hard to convince neurologists and neurosurgeons that we are better at looking at the images. We may be better looking at them, but are we better at interpreting them? And that, I think, is going to be a battle for the next decade or so. The buzzword, as I said, is artificial intelligence. AI is a threat for some and a boon for others. Like all changes, all new things on the horizon, there's two sides to every coin, right? I don't believe it's a threat. You could look at it as a threat. I think AI is going to do a tremendous job taking out of our hands the mundane stuff. Is there a wrist fracture or not? Good research on that already. Is there an intracranial bleed or not? That choose to be a radiologist after 45 years. The answer is unqualified yes. But how? It will be different than when I started. And I do believe, even though I'm a boomer, it is still the cog of the hospital working well. Thank you for listening, and thank you again for asking me to be your honored guest. Thank you.
Thank you very much, sir. We have now arrived at another significant moment of this evening, which is the awarding of fellowships. To read the citations of those who are awarded, I cordially invite Dr. Buddhi Galabada, consultant radiologist at Base Hospital, Homagama.
Good evening. Honorable Chief Guest, Professor Senaka Rajapaksha, Guest of Honor, Prof. Hans Bigman, President, Sri Lanka College of Radiologists, Dr. Gerard Fernando. I consider it great honor and privilege to be given this opportunity to present the citations in honor of my teachers and senior colleagues who will be receiving fellowship awards tonight. Their immense contribution to uplifting the standards of radiology in Sri Lanka is greatly appreciated. It gives me the great pleasure to introduce the recipient of first fellowship award tonight, Senior Consultant Radiologist, Dr. D.D. Ranasinghe. Don Dhammika Ranasinghe was born on 8th of October 1958 in Kolonnawa. He received his primary education at Siddhartha Mahavidyalaya Kolonnawa and pursued his secondary education at Central College Kottahena and Ananda College Colombo. He graduated from Faculty of Medicine, University of Colombo in June 1982 and served the Ministry of Health as a medical officer from 1982 to 1994, during which period he served in many regional and provincial hospitals in Sri Lanka. He entered postgraduate training in radiology in the year 1994 and obtained his training in radiology at National Hospital of Sri Lanka, the largest tertiary care hospital and the main referral center in the island. He successfully completed MD Radiology in year 1997. He obtained his overseas training as a fellow in radiology at New Children's Hospital and Adult Hospital in Westmead, New South Wales, Australia, where he was highly commended for his work by his supervisors. Subsequent to the board certification in December 1998, Dr. Ranasinghe served at radiology departments of several provincial general hospitals in Sri Lanka, such as General Hospital Badulla, District General Hospital Gampaha, and General Hospital Kalutara. He rendered a tremendous service as the consultant radiologist in charge of Colombo South Teaching Hospital from 2009 until his retirement in October 2021. He is currently enjoying a peaceful retirement life while continuing to render his services to the patients in private sector with a vast experience behind him. Dr. Ranasinghe was an active member of Sri Lanka College of Radiologists. He rendered a commendable service as an invaluable member of the Abstract Review Committee of the annual academic sessions over the past years. He also served as the editor of the Sri Lanka Journal of Radiology for several years. He represented Colombo South Teaching Hospital at the Board of Study in Radiology at Postgraduate Institute of Medicine from year 2009 to 2013. Furthermore, he was an examiner at both Part 1 and Part 2 MD Radiology examinations for many years. Dr. Ranasinghe served in the capacity of supervisor to radiology trainees from year 2009 to 2021. He was an excellent teacher and a supervisor to many of the radiology trainees of Colombo South Teaching Hospital. I invite President Sri Lanka College of Radiologists to confer Dr. D. Ranasinghe with Fellowship of Sri Lanka College of Radiologists. Now, let me introduce the next recipient for Fellowship Award tonight, Dr. Shanta Hettiarachchi. Patirenna Helage Shanta Hemantha Hettiarachchi was born to Mr. and Mrs. Piyadasa on 23rd of August 1965. She obtained her primary and secondary education from Ferguson High School, Ratnapura. Dr. Shanta Hettiarachchi graduated from Faculty of Medicine, University of Peradeniya with a second-class honours in year 1991. She entered in-service postgraduate training in radiology in the year 1994 and obtained her pre-MD training as a registrar in radiology at National Hospital of Sri Lanka. Dr. Hettiarachchi successfully completed her MD radiology in 1998. She served at Sri Javardhanapura General Hospital, Kotte from 1998 to 1999 as a senior registrar in radiology during her post-MD local training. Dr. Hettiarachchi completed her overseas training fellowship at Queen Elizabeth Hospital, Adelaide, South Australia from 1999 to 2000. After board certification as a consultant radiologist in year 2000, Dr. Shanta Hettiarachchi served the Ministry of Health Sri Lanka as a consultant radiologist at Base Hospital, Kuliyapitiya and Teaching Hospital, Karapitiya from year 2000 to 2002. During this time, Dr. Shanta Hettiarachchi pioneered the establishment of Department of Radiology at Base Hospital, Kuliyapitiya as the first radiologist appointed there. She later joined the private sector as a consultant radiologist in the year 2002. Since then, she served as the consultant radiologist at head of department at Apollo Hospital, Colombo 5 and Asiri Surgical Hospital, Colombo 5. She is currently rendering her services as the consultant radiologist and head of the Department of Radiology at King's Hospital, Colombo since 2019. After joining private sector, she rendered a commendable service in establishing radiology departments in 3 leading private hospitals, Lanka Hospital, Asiri Surgical Hospital and King's Hospital, Colombo. She was a pioneer in initiating certain specialized diagnostic imaging modalities and interventional procedures in the private sector of Sri Lanka. Dr. Shanta Hettiarachchi has a specialized training in CT coronary angiogram and cardiac MRI and initiated cardiac imaging in Sri Lanka in year 2003 and cardiac MRI in 2004. Together with Dr. Sanjeeva Munasinghe as a local colleague and Prof. Santosh Joseph as a resource person, she initiated neurointerventional procedures in 2007. Furthermore, Dr. Shanta Hettiarachchi established the first digital mammography unit with tomosynthesis and vacuum-assisted biopsy in year 2014. She has a special interest in MRI body imaging, including fetal MRI, breast MRI, and prostate MRI. She is an active and versatile member of the Sri Lanka College of Radiologists. Dr. Hettiarachchi has served as a council member of Sri Lanka College of Radiology and has held executive posts in the council for many years. She has presented many research papers at academic sessions of College of Radiologists and has contributed to international multicentric research work. Dr. Shanta Hettiarachchi has delivered many guest lectures in Sri Lanka College of Radiology sessions as well as in other academic bodies, including many colleges' peripheral clinical societies. Dr. Hettiarachchi is also an excellent teacher, and she has conducted many lectures and film viewing sessions for MD radiology trainees. She has also contributed to MCQ core group MD Radiology Part 1 examination for many years. I invite President Sri Lanka College of Radiologists to confer Dr. Shanta Hettiarachchi with the Fellowship of Sri Lanka College of Radiologists. Next, let me introduce the third Fellowship Award winner tonight, Dr. A.N.I. Vijayasinghe. Alawathurage Nirmala Airangani Vijayasinghe was born on 18 September in Colombo, Sri Lanka. She received her primary and secondary education in Vishaka Vidyalaya, Colombo, where she excelled in both curricular and extracurricular activities. She was a school prefect and a member of the debating team. Dr. Vijayasinghe received the Indian Cultural Scholarship and graduated from Savai Man Singh Medical College, Jaipur, Rajasthan, India in 1984. After graduation, Dr. Vijayasinghe joined the Ministry of Health, Sri Lanka in the year 1985. After completing her internship at Sri Javadanapura Hospital, she served as a medical officer at the Institute of Cardiology, Colombo. Dr. Nirmala Vijayasinghe joined the Department of Radiology, National Hospital, Colombo for her postgraduate training in radiology in the year 1991 and successfully completed her MD radiology in year 1995-96. Then she served at the Neurosurgical Unit, National Hospital of Sri Lanka prior to her overseas training. Her post-MD overseas training was completed at National University Hospital, Singapore, Tan Tock Seng Hospital, and at the National Neuroscience Institute, Singapore in the years 1999 and 2000. After board certification as a consultant radiologist in year 2001, Dr. Vijayasinghe served the Ministry of Health Sri Lanka as a consultant radiologist at Teaching Hospital Karapitiya, Base Hospital Avissavella, Teaching Hospital Ragama and District General Hospital Chilaw. She later joined private sector as a consultant radiologist in the year 2003 and has since then rendered her services at many renowned private hospitals in Colombo. She is an active member of many radiological societies. She has been a council member and social secretary to the College of Radiologists of Sri Lanka. Dr. Vijayasinghe was a founder member of the Asian Musculoskeletal Society and also a member of Asian and Oceanian Society of Head and Neck Radiology. She chaired the sessions at the American Society of Head and Neck Radiology in Bangkok in year 2012. Dr. Nirmala Vijayasinghe has submitted many papers to Asian Musculoskeletal Society, Korean Society of Radiology, World Congress of Neuroradiology, and American Society of Head and Neck Radiology during the period of 2013 to 2021. She has also presented papers at academic sessions of Sri Lanka College of Radiology and Sri Lanka College of Pulmonologists. She also served in the capacity of Honorary Secretary to the National Council of Mental Health. I cordially invite President Sri Lanka College of Radiologists to confer Dr. I.N.R. Vijayasinghe with Fellowship of Sri Lanka College of Radiologists. Finally, let me introduce Dr. Sampath Goroggahagoda, who will be receiving the next fellowship award. Sampath Goroggahagoda was born to Mr. David Goroggahagoda and Mrs. C.A. Somawati on 6th October 1969 in Colombo. Dr. Goroggahagoda obtained his primary and secondary education from Richmond College, Galle, and passed out in 1988. He graduated from Faculty of Medicine, University of Ruhuna in the year 1997 with second-class honors and served as a demonstrator at the Department of Community Medicine, University of Ruhuna from 1997 to 1998. Dr. Goroggahagoda served as a medical officer for the Ministry of Health, Sri Lanka at MICU of National Hospital of Sri Lanka and Cardiothoracic Unit of Teaching Hospital, Karapitiya from 1998 to 2000. He entered in-service training in radiology in October 2000 by joining the Department of Radiology and Nuclear Imaging in National Hospital of Sri Lanka. He successfully completed MD Radiology in year 2003. Dr. Goroggahagoda obtained his overseas training as a fellow in radiology at John Hunter Hospital and Calvary Mater Newcastle Hospital, Hunter New England Area Health Services, Newcastle, Australia, from October 2006 to July 2008. During this period, he developed a special interest for interventional radiology. After his board certification as a consultant in diagnostic and interventional radiology, he served in many hospitals of Sri Lanka under the Ministry of Health, which include District General Hospital Ampara, District General Hospital Navalapitiya, Sirimao Bandaranayaka Specialized Children Hospital and Teaching Hospital, Kandy. He is currently serving as a consultant in diagnostic and interventional radiology at the Interventional Radiology Unit of Teaching Hospital, Kandy. He has participated in many workshops and certificate courses to update his knowledge and skills in radiology. He has a special interest in interventional radiology and has shown a competency in wide range of interventional procedures. Dr. Sampath Goroggahagoda is a member of the Sri Lanka College of Radiologists and Kandy Society of Medicine. He has presented many free papers and posters at academic sessions of Sri Lanka College of Radiologists and at the joint scientific meeting of Sri Lanka College of Radiologists and Asian Musculoskeletal Society in year 2005. Dr. Goroggahagoda has conducted many lectures at Kandy Medical Society sessions and was a resource person at the workshop in hepatology in September 2016 and instructional course in emergency medicine in November 2018. He was a chairperson at the 8th annual academic sessions of Sri Lanka College of Pulmonologists in 2018. Furthermore, he has conducted many formal and informal teaching sessions to postgraduate trainees in radiology, medical and surgical postgraduate trainees, medical students and nurses. Dr. Goroggahagoda was an examiner for both MD Part 1 and Part 2 radiology exams held by the Postgraduate Institute of Medicine. Now, I invite President Sri Lanka College of Radiologists to confer Dr. Sampath Goroggahagoda with Fellowship of Sri Lanka College of Radiologists. Thank you very much.
Thank you, Madam. Next in the agenda is the awarding of Memorial Gold Medals. May I cordially invite Dr. Gerard Fernando, President, Sri Lanka College of Radiologists, on stage. The Dr. SNB Talwatta Memorial Gold Medal for Outstanding Performance in MD Radiology Part 2 Examination 2020 is awarded to Dr. Murugavel Mayuran. The Dr. Ananda Thukorala Memorial Gold Medal for Outstanding Performance in MD Radiology Part 1 Examination 2020 is awarded to Dr. Thenuka Sivasundara. Award of Felicitations. Recognizing 20 years of invaluable service as a lecturer in radiography and his contribution to the postgraduate training of many hundreds of radiologists, the Sri Lanka College of Radiologists is honored to felicitate Mr. Vittarana Gamage Vimalasena, the former principal of the School of Radiography at National Hospital of Sri Lanka. Mr. Vimalasena, we warmly invite you on stage to accept this token of appreciation for your services rendered to the betterment of the field of radiology.
Thank you, sir. An event of this magnitude would not have been possible without the hard work and wholehearted contributions by many. It is my duty to invite Dr. Udita Kodituakku, Honorary Secretary, Sri Lanka College of Radiologists, to propose the vote of thanks.
The chief guest, Professor Senaka Rajapaksha, our guest of honor, Professor Hans Blickman, our orator today, Dr. Hiroshini Kodikara, President and past presidents of Sri Lanka College of Radiology, council members, invited dignitaries, my dear colleagues and friends. I am deeply honored and privileged to deliver the vote of thanks tonight on behalf of Sri Lanka College of Radiologists. First of all, I would like to thank our chief guest, Professor Senaka Rajapaksha, Director, Postgraduate Institute of Medicine and immediate past president of Ceylon College of Physicians, for accepting our invitation and gracing this evening. Dear sir, we warmly appreciate your commitment and continuous support to the academic activities. I must express my gratitude to Professor Hans Blickman, Professor Radiology and Pediatrics from University of Rochester Medical Center, USA, for attending as the guest of honor this evening, despite his extremely busy schedule and prevailing pandemic situation. Thank you, sir. We thank our orator, Hiroshini Kodikara, for delivering Dr. SNB Talwatta Memorial Oration. We are expecting to witness your enlightening presentation tonight at this elegant event. The team of speakers from overseas traveled far and wide to be emissaries of knowledge and experience at this Congress despite of the current pandemic. We sincerely thank all of you for spending your valuable time and effort to share your vast knowledge and experience with us. I must not forget our local faculty. Thank you very much for your generous contribution. Heartfelt gratitude is committed to organizing committee for their untiring effort to make this event a success. I will fail in my duty if I do not thank all the past presidents and previous councils for their contributions to bring our college to this present status. Though I cannot mention individual names due to lack of time, my sincere thanks goes to all the council members and the members of organizing committee for making this event a success. I want to say a big thank you to Dr. Prasanna Jayasekara, consultant radiologist, for designing the front cover of the souvenir, which he has been doing for many years. A very big thank to our generous sponsors. Without your support, this event would not have been a success. Thank you, Med Equipment Limited, for being our sole platinum sponsor, and also Philips Lanka Solutions Private Limited, Haley's Life Sciences, Sunshine Healthcare, Bayer Healthcare Pharmaceutical Private Limited, Global Med International Private Limited, Imendra Healthcare, Medi Technology, and Biomed Private Limited. Thank you all. On behalf of Sri Lanka College of Radiologists, I must also thank Mr. Sujeeva and his team, Tamarin Events, for their IT support and technical facilitation. The General Manager, Mr. Kamal Munasinghe, and the staff of Cinnamon Grant, Colombo, who have contributed us in numerous ways in making this event a success. I must thank Ravidu Printers for doing a marvelous job, Mr. Jayasekara and his son for capturing and keeping all our wonderful memories in his camera. Last but not least, I should thank Dr. Nilushi Hevavasam and Ms. Sevwandi for their contribution in organizing this event. I really appreciate you. Please bear with me for not mentioning each and every one of you due to my time constraints. At the efforts of our friends who contributed to the success of this event are sincerely appreciated by the Council of SLCR. Have a pleasant evening, ladies and gentlemen. Thank you. Honorary Secretary, Sri Lanka College of Radiologists. Thank you very much.
Thank you, Madam. Ladies and gentlemen, now we have reached the key moment of this evening, which is the Dr. S.N.B. Talwatta Memorial Oration for 2021. May I now invite Dr. Gerard Fernando, President, Sri Lanka College of Radiologists, to introduce the orator.
Dr. Samararatna Kankanamge Yamuna Iroshani Kodikara was born on August 24, 1977, as the first child of Mrs. Nita Ranjani and the late Mr. Dharmasena Kodikara. She received her primary education from St. Mary's Convent Mathura and entered Devi Balika Vidyalaya, Colombo, for her secondary education. In 1998, she gained admission to Faculty of Medicine, University of Colombo, where she completed her medical degree in 2004, passing with honors. After internship, she served as a senior house officer at District General Hospital, Mathura, and entered the training program in radiology in 2008. She did her pre-MD training at Sri Javadhanpur General Hospital and obtained her MD in radiology in 2001. She was at Children's Hospital at Westmead, Sydney, Australia for 2 years, where she completed a fellowship in pediatric radiology. After returning to Sri Lanka, she worked as a consultant radiologist attached to Ministry of Health for a few years before joining the Ruhuna Medical Faculty in 2016, where she continues to work as a senior lecturer to date. She has published many articles in national and international journals and contributed to several book chapters, and also has co-authored Color Atlas of Human Anatomy, Abdomen. She has over 40 publications and 15 citations. She has received many research grants and has served as an assistant editor to the Sri Lanka Anatomy Journal and is also an assistant editor to the Sri Lanka Journal of Radiology. She has been in the Council of Sri Lanka Radiology for many years and has been a valuable member of the Board of Study in Radiology. She has worked hard to promote research and publications among the radiology trainees. Her oration is related to the pandemic we all know and is titled Chest Radiographic Risk Stratification in COVID-19 Pneumonia. Thank you. May I welcome Dr. Hiroshini to present her oration. Thank you.
May I invite the President of the Sri Lanka College of Radiologists to present the Orator's Medal to Dr. Kodikara.
President, Sri Lanka College of Radiologists, Dr. Gerard Fernando, Chief Guest, Professor Senaka Rajapaksha, Guest of Honor, Professor Hans Blickman, past Presidents of Sri Lanka College of Radiologists, members of the Council, family members of late Dr. S.N.B. Talwatta, invitees, colleagues and friends. Good evening. It is a great honor and privilege for me to stand here in front of this august gathering to deliver the Professor Dr. S.N.B. Talwatta oration. Dr. Surendranath Bandara Talwatta was born on 29th October 1924 to Mrs. Tikiri Kumari and Dr. Jayasundara Talwatta in Kandy. He attended Trinity College, Kandy, where he excelled in his education. Dr. Talwatta entered the medical faculty in 1946 and graduated in 1951. Soon after his graduation, he married Miss Kiriella and served the country as a medical officer at Castle Street Hospital and General Hospital, Kandy, before he went to UK for his postgraduate studies. He has specialized as a radiologist. On his return from UK in 1958, Dr. Talwatta was appointed to General Hospital Galle. He was the second radiologist to serve outstations. He has also served at Kurunegala and Kandy, then appointed to General Hospital Colombo in 1968. He has pioneered the radiology literature in Sri Lanka by publishing many articles. His research field of interest was the lung changes in tropical pulmonary eosinophilia. In 1971, he received international recognition as a speaker at First Asian and Oceanic Congress of Radiology in Melbourne. He also chaired a symposium in this congress. Dr. Talwatta pioneered the postgraduate studies in radiology in Sri Lanka, which commenced in 1980, leading to MD Radiology. Dr. Talwatta was the first chairman of the Board of Study in Sri Lanka Radiology. Concurrently, he served at the Board of Management of Postgraduate Institute of Medicine. He was the founder president of College of Radiologists in Sri Lanka, which was later named as Sri Lanka College of Radiologists. He was a loving brother, a caring husband, and a model father. His youngest daughter, Kishani, followed his father's footsteps and is now a leading consultant radiologist in the country. After his retirement in 1990, he continued to play an active role as an advisor and patron to the Sri Lanka College of Radiologists until his passing on 16 July 2010. He paved the path of radiology not only to his daughter but to many more young radiologists, many more young doctors. He was the tower of strength to the field of radiology in Sri Lanka, a humble, friendly, and a pleasant personality who deserved to be honored. Ladies and gentlemen, in dedication to this great personality, please let me proceed with Dr. S.N.B. Talwatha Memorial Oration. I know I do not have to introduce COVID-19 to this educated audience. However, formalities should be followed. As we all are aware, COVID-19 is caused by severe acute respiratory syndrome, coronavirus 2. It was first identified in China in December 2019. With subsequent rapid global spread, WHO declared a pandemic in March 2020. Since then, there were many outbreaks with emergence of novel viral strains. Understanding the virus is important to understand the pathogenesis and virulence. This RNA virus spreads rapidly through close contact via aerosols and respiratory droplets. It was named considering its unique appearance. Under the microscope, it has a crown-like structure formed by membrane proteins. S protein allows the viral fusion to the host cell membrane angiotensin converting enzyme 2 receptor. This receptor fusion is facilitated by the action of serine proteases. Expression of AC receptors, proteases varies by tissue type and location. Their expression is important for pathogenesis. They are highly expressed in nasal and bronchial epithelium. Also in the human conjunctiva, gastrointestinal tract, liver and kidneys. Therefore, viral entry into the human body, maturation, replication occurs at these sites. After the viral entry, containment of infection and viral clearance occurs in 80% within 10 to 14 days. Approximately a fifth develops symptoms when the virus replicates in the upper airway or migrates into the lower airway. When the virus enters the type 2 pneumocytes, the host immune response is activated. The magnitude of immune response is related to the degree of lung injury. However, there are many unanswered questions regarding the pathogenesis of severe COVID. Up to now, the pathogenesis is explained by the cytokine storm, diffuse alveolar damage, thrombotic or microangiopathic vasculopathy. The radiological diagnosis of COVID pneumonia reflects the radiological findings, in fact, reflects the pathological changes. Ground glass opacities and the consolidation are the frequently found opacities in COVID pneumonia. Ground glass opacities represent a hazy area in the lung field through which the pulmonary vessels are visible. Consolidations are opacities with obscured blood vessels. We can't identify blood vessels through a consolidation. Usually, the lung opacity is seen in the peripheries of both lungs. Lower zone involvement is predominant. Ground glass opacities reflects mid-phase of diffuse alveolar damage. That was the pathology. And consolidation pattern mainly associated with late phase of diffuse alveolar damage. The high mortality and morbidity rates are the first and foremost impact of COVID-19 on mankind. Apart from unprecedented challenge to public health, it has shaken the smooth establishment of food systems and the world of work. Despite having successful vaccination programs, this ever-expanding pandemic overloaded the healthcare system, creating a huge demand for resources. Therefore, difficult resource allocation decisions are to be made between COVID-specific requirements and other health needs. A huge healthcare expenditures are a burden to country's economy. COVID-19 disease severity is influenced by several factors. Disease spectrum ranges from asymptomatic to mild infection and to severe infection. The major recognized risk factors of severe infection include male gender, smoking, associated comorbidities. The magnitude of risk may change under different geographical or genetic influences. Data on risk factors are scarce for Sri Lanka. UA Lianage et al. Have conducted a multidisciplinary study in Sri Lanka during the first wave. They identified a positive relationship between chest X-ray severity and male gender, comorbidity and advanced age. Anyhow, expanding the knowledge on imaging features and risk factors of severe infection is an urgent need. Once the risk groups are identified, triaging principles can be applied for resource allocation. The word triage means to classify or to sort. Triaging is a promising solution to many economic and resource demands. Triaging will help to direct resources efficiently to needy patients, and it will ensure patient survival while reducing the demands. Therefore, an efficient triaging system is the cornerstone to cope up with increasing demands of this pandemic. Sri Lanka, as Sri Lankans, we have successfully applied this triaging concept to decide on patient admission. The high-risk patients were admitted and low-risk patients were directed for home management. Our study center, the base hospital Homagama, is a dedicated national COVID-19 multidisciplinary treatment center. It admits COVID patients with associated comorbidities. So high-risk patients are admitted to our study center. Additionally, triaging has been used for ICU admissions and for ventilator allocations. These triaging decisions were made based on global data. It is important to update these guidelines based on national data. In ICU, the patients have been triaged as per the guidelines of sepsis management. SOFA score, Apache 2 score, SIR score are few that have been used. These scores calculate using multiple bedside parameters and blood investigation. Therefore, time and cost are their limitations. If I show you, if I give you a rough idea regarding this SOFA score, it assesses multiple parameters: respiratory parameters, coagulation parameters, liver, cardiovascular, CNS, and renal parameters. Using these parameters, they assign a score. And this is how a SOFA score, for example, a SOFA score-based triaging is done in ICU. There is a triaging code. Initially, the exclusion criteria have to be applied when we are triaging using a code. If the triaging code is green, that patient is at low risk. Therefore, the patient can manage without admitting to ICU or further intense care. So if the triage score is less than 7, that means the patient is at risk, need intubation, admit to ICU care for aggressive therapy. Red means 8 to 11. So patient, if the resources are available, patient will be admitted to ICU. If not available, then put into the blue line. Blue means the patient is beyond recovery. So resource allocation is limited to such patients. That is how a triaging is practicing. Having a simple triaging tool is extremely useful when demands are high. Since chest X-ray is freely available, cost-effective investigation, we have evaluated the possibility of developing a chest X-ray based triaging tool. Severity scoring systems have been used in this pandemic for quantitative assessment of lung involvement. These are the severity scoring system available at the moment. The few available severity scoring systems use different methodologies. Scoring system 1 and 2 use the lung area involved. In contrast, and compared to system 1, a wide score is allocated by the system 2. In contrast, the scoring system 3 consider the lung infiltrative pattern. Scoring system 1 allocate a score to whole lung, while 2 and 3 allocate to a zone. Importantly, none of these available systems are validated for COVID pneumonia. To ensure the reliability of a tool, validation process is essential. Methods used by the existing tools are not uniform. I must emphasize that the type and the distribution of lung opacities are related to disease severity. The ground glass opacities represent early or less severe stages. They represent less severe disease than consolidations. Lower percentage lung involvement is considered less severe. Therefore, we believe a severity scoring system to reflect the clinical severity should assess both area involved and the density pattern. Therefore, in this oration, I aim to provide clarifications to 3 outstanding questions through a series of studies done by us in Sri Lanka. The 3 questions are: what are the demographic features and risk factors of fatal outcome? What are the chest X-ray features of COVID pneumonia in patients with fatal outcome? What is the best radiographical risk assessment method? Those are the questions I am going to clarify in this oration. For this, we have performed a series of studies from 2020 to 2021 in 2 phases, including COVID-infected symptomatic adults treated at Base Hospital, Homagama. In the COVID second wave, we have assessed chest X-ray features. In the third wave, we studied CT features. I'm sorry, there is a confusion in the slide. No, it's okay in the upper. Yeah. Okay, sorry about that. In the second wave, we assessed chest X-ray features. In the third wave, we studied chest CT features. This oration is focused on the data from the second wave. We included 300 patients to record chest X-ray features according to the definitions of Fleischner's glossary. The chest X-rays were double read by 2 radiologists to allocate a score and to assign the signs. The patient outcomes were categorized as non-severe, severe, or fatal. A severe case was classified if the patient needed an ICU admission or is deceased. We have considered only the short-term outcomes. We haven't considered the long-term outcomes once the patient's been discharged from the hospital. Now on, I will describe the demographic features of severe COVID and the risk factors associated with severe and fatal outcomes. That is the clarification for the question number 1. Our patients were aged 18 to 87 years with mean age of 58 years. We reported a high case fatality rate, that was 18.3. The case severity rate was 24.3. Despite optimum management in our study center, this case fatality rate remained higher than the national figures. The national figures during the second wave was 0.64%. This reflects the impact of COVID-19 disease on high-risk patients. 84% of our patients had at least one coexisting medical condition. More than 50 had diabetes and hypertension along or in combinations. 30% had chronic kidney disease. In analysis, we found diabetes and chronic kidney disease as significant risk factors for fatal and severe infection. They were associated with severe and fatal infection. Females were in the sick majority, but the severe disease was more prevalent among males. The gender influence on disease severity was significant. The risk factors for severe infection include male gender, low oxygen saturation at the time of chest X-ray, and having comorbidity. Males have shown twofold higher risk for severe disease. Comorbidity has increased the risk by 5-folds. Male gender influence on disease severity was apparent globally as well. Some attributed it to the effect of sex hormones on immunity. Estrogen seems to have an immune protective effect. Alcohol, cigarette smoking also reduce cellular and pulmonary immunity. The high prevalence of comorbidities among the males is probably contributing to increased disease severity. But for this cohort, the male gender was not a risk factor for fatal infection. Low oxygen saturation was a risk factor for both severe and fatal infection. Low oxygen saturation reflects the severity of lung involvement. The manuscript including these findings are submitted as original article to SN Comprehensive Clinical Medicine Journal, and it is in the publication process. Now I will describe the chest X-ray features, the temporal sequence, and their association to the fatal outcome. For this, we exclusively included the chest X-rays that only have COVID-19 lung disease. We have excluded all the other chest X-rays from the study. We have done this using the patient's clinical diagnosis and using other preliminary data. We assessed 289 chest X-rays of 228 patients. Averagely, a chest X-ray was taken on day 7 of illness. Nearly 50% of suspected pneumonia patients had at least one normal X-ray, maybe in initial phase. Normal chest X-rays were more common among the survivors. Chest X-ray positivity rate was associated with disease outcome. 75% of fatal cases had typical COVID pneumonia findings in their chest X-rays. The most frequent chest X-ray findings of COVID pneumonia were patchy ground glass opacities, patchy consolidations. Importantly, lobar or segmental consolidations were not found as features of COVID pneumonia. Also, lung nodules, masses, hilar lymph nodes, pneumothorax, pneumomediastinum were atypical for COVID. We have seen pneumomediastinum when the patients were intubated and as a complication. The predominant opacity pattern in fatal case was consolidation. Ground glass opacities was predominant among the survived patients. Features such as reticular shadows, atelectic bands, pleural effusions have not shown an association with the disease severity. The lung involvement in COVID pneumonia was always bilateral. Asymmetrical involvement was most frequent than symmetrical pattern. The right lung was more severely affected in fatal cases. That was statistically significant. However, in early 2020, bilateral symmetrical lung involvement was described as COVID-19 feature, pneumonia feature. But we and some recent studies have observed an asymmetrical pattern. We also noted left lung involvement was late to occur and early to clear. We noted supero-inferior gradient in severity of lung involvement. The lower zones were more severely affected. They infiltrated early and late to clear. We observed a positive association between the percentage lung involvement and the disease severity. Nearly 50% of fatal cases had opacities in more than 50% of lung fields. Only 25% of survived had more than 50% lung field involvement. Therefore, the area involvement was significant in fatal cases. The radiographic severity and clinical severity were associated positively. We have classified the radiographical severity as mild, moderate, and severe using the score. I will explain it later. 80% of survived had normal chest X-ray or a chest X-ray with mild severity. 50% of fatal cases had moderate or severe radiographic grading. These findings were clinically significant, statistically significant. And to assess the temporal progression of the chest X-ray features, the disease was categorized into 4 stages as early, progressive, peak, and resolving, considering the PCR date as day 0. There was a clear temporal progression in lung opacities. The chest X-rays were frequently normal in early stage. With the disease progression, the lungs were infiltrated with consolidations and ground glass opacities. Reticular opacities were frequent in resolving phases. The climax of the lung involvement was found in the peak stage. The severity score has shown a similar temporal progression. The highest severity scores were seen in the peak or the stage 3. We have evaluated the factors related to chest X-ray severity. Male gender and disease stage were independent risk factors for chest X-ray severity. The male gender had 4-fold risk for developing radiographically severe disease, that is similar to the general gender risk. The manuscript related to these findings is submitted as an original article to SN Comprehensive Clinical Medicine Journal. It is under consideration for publication. I have to present these data without waiting for publications, as this is a hot topic nowadays. As I have pointed out earlier, validation of a simple radiological triaging tool is the holy grail of this study. Hereon, I will describe the related findings. For this purpose, we have assigned chest X-ray severity scores to 147 chest X-rays with typical COVID-19 pneumonia. We have developed 3 severity scoring systems by modifying Raleigh scoring system. Raleigh scoring system is radiographical assessment of lung edema that was validated to assess lung edema in ARDS. Raleigh score assesses lung density and area involved in lung quadrant. Since COVID pneumonia has shown supero-inferior gradient, we divided the lung into 3 zones by 2 horizontal lines. That's how we allocated the score. The 3 scoring system assess lung involvement using different methodologies. Our aim was to identify the best out of them. We have done this study because considering the inhomogeneities of existing scoring systems. So we have tried 3 methods and tried to find the best out of these. The area scoring system described as evaluate the percentage lung area involved. A score of 1 to 4 is allocated to the entire lung. We have allocated the score of 1 if the area involvement is less than 25%, and we have allocated a score of 4 if the area involvement is more than 75%. Using the total severity score of the patient, we have decided the chest X-ray severity as mild, moderate, and severe. The maximum score of the patient was 8 and the minimum is 0. Area and density scoring system assess percentage lung involvement and the infiltrate pattern. Score is allocated to the whole lung. Since ground glass opacities represent less severe disease, we have given a score of 1. For consolidations, we have allocated a score of 2. The total score of the lung is multiplication of area and density scores. The severity grade was assigned accordingly as for the previous score. So here the total score is 16 and the minimum is 0. As there is a multiplication, score range is very high. In the new scoring system, we have allocated a score to 1/3 of lung. We want to assess whether it is correct to allocate a score to the whole lung or a zone. What is the correct method? That's what we have done in this third system. Otherwise, the methodology is similar to the area and density score. The highest score here is 48 for the patient. The main difference between the area and density score and the new score is the assessment field. The latter allocates a score to 1/3 of the lung. This is the method of calculation the severity score. I will use the cursor. Here, the patient is, I'm describing the new severity scoring system. The two horizontal lines divide the lung fields. The first line is at the aortic knuckle level, and the second line is inferior pulmonary artery level. This is the upper zone, no infiltrates, therefore the score is 0. Here, consolidations are there, 25 to 50% area, therefore the score is 2/2. And here the consolidation opacities are there, less than 25% of area involvement, therefore the score is 2 for that field. Total score is calculated using the area scores of 6. And in this chest X-ray, severity we have classified as mild. And the second patient, the extensive area involvement, but the opacity pattern is ground glass opacities, therefore the total score came as 22 and moderate severity. And compared to that, this patient is having the same area involvement, but the pattern is consolidation. The total score is 36 and we have classified it as severe. Now, the patient outcome and clinical severity were reflected by all three scoring systems. Statistically significant difference was there. High severity scores were seen in fatal cases and the difference was significant. Therefore, we included all three scoring systems for validation analysis. With high area under the curve, all three systems were validated for mortality prediction. The sensitivity of the scoring system to predict mortality was nearly 70%. Specificity ranged from 50 to 70%. And we calculated cutoffs values of all three scoring systems. Importantly, all three systems have shown high negative predictive values. Therefore, they can be used to identify the patient who are at low risk of getting fatal disease. These findings indicate the reliability of severity scoring system as a triage tool. As we predicted, the scoring system that assessed both percentage involvement and the density pattern was better as a triage tool. The two scoring systems were better as triaging tools. Among them also, the new score, which has predicted a better outcome. That new score, we have allocated the score to a zone. The related findings were presented as an abstract in Respire 2021, and the relevant manuscript has been accepted by Ceylon Medical Journal, now in the preprint stage. The accuracy of scoring systems can be reduced by poor image quality. Therefore, technical factors such as patient positioning, respiratory effort, motion artifacts, exposure factors, and imaging viewing conditions to be optimized. If we can't control the above things, we have to control the image viewing conditions to get the optimum results. Image viewing condition is particularly important to detect subtle signs such as ground glass opacities. Improving the interpreter's expertise to detect these signs is equally important. I need to emphasize one more important fact. It is extremely important to differentiate non-COVID lung disease from COVID lung disease before calculating a severity score. We have described chest X-ray scores as triage tools. But CT chest is more sensitive to detect ground glass opacities. Then why not a CT score? CT involves high radiation dose. Therefore, follow-up CTs, when it is required to monitor the COVID patients, patients are exposed to high radiation dose, therefore hazardous in long-term outcome, long run. On-site chest X-ray is helpful when CT is not available or practically difficult when the patients are difficult to move into the CT suits or need intense patient disinfections in the CT suits. Importantly, with adequate supportive evidence, the European Society of Radiology and European Society of Thoracic Imaging have recommended follow-up chest X-rays for patient monitoring in ICU, but low use as a initial diagnostic tool. Therefore, chest X-ray has its own pearls as a triaging tool. Yeah, this is the COVID chest X-ray reporting format currently practicing at Base Hospital Homagama. This is not the data collection form, the reporting format. Dr. Buddhi Galabata has designed it. To conclude, in last 30 minutes, I have pointed out many facts related to COVID imaging. We sincerely hope these findings will be incorporated into future practice. I would like to thank my dear colleague, Dr. Buddhi Anjani Galabada, consultant radiologist based Hospital Homagama. She was my classmate, batchmate, and now my research partner. Without her support, this research will not have been accomplished. I would also like to express my appreciation to the enthusiastic research team, the medical officers from the Department of Radiology Base Hospital Homagama. I found it was very easy to work with them. I would like to thank all the patients participated, the director and the staff of the Base Hospital Homagama, Ministry of Health for funding. My sincere gratitude goes to President and the Council of Sri Lanka College of Radiologists for giving me the opportunity. I would like to voice my gratitude to my dear parents. They are the pillars of my success. I especially thank my mother for being with me all this time. I would like to thank my dear husband Anusha, my children Anuk and Dinugi for tolerating me during extra working hours and also for their love and encouragements. I would like to thank my first mentors in radiology, Dr. Jayantha Vikramaratne, always had faith in his trainees. Dr. Varusavithana, who was quick to rejoice in his success in his trainees. Dr. Priyangi Arembapola, who taught me accurate scientific drafting. She knows what she has done. Thank you very much. I would also like to express my sincere gratitude to Professors B.G. Nanayakar and Professor Isurani Loperuma, who laid the foundations in my research career. Without them, I would not have come this far within this short period. It's only been 5 years. I would like to remember all the teachers who have guided and aided me through my journey. I am extremely sorry there are so many. Pardon me for not mentioning them by name. Thank you. Thank you to them all. Thank you very much.
Thank you very much, Madam, for enlightening the audience with that excellent oration. We now draw towards the conclusion of the formal ceremony, which will be marked by the academic procession leaving the hall. Please rise as the procession leaves the hall.
And with that, we come to the conclusion of today's event. Fellowship and cocktail awaits you. A gentle reminder to all our eminent guests to please follow all health and safety guidelines that we have implemented to ensure that we all have a safe environment to make this a memorable night. Have yourselves a pleasant evening. Thank you.